My name is Stefan Hartman, physician assistant, exercise science specialist. Welcome to my part 3 in things we do in medicine based on flawed evidence. We're going to talk about interventions. So a couple things we're going to talk about are low salt diets to reduce hypertension and improve cardiac risk. Is an intervention not based in good science with many side effects. Calorie in, calorie out is the only way to lose weight. This is partially false and is putting diabetics and those at risk for metabolic syndrome at increased risk. Stents for stable angina don't improve symptoms in a sham study. Evidence for back surgery is highly variable, but may really depend on the surgeon, which we kind of do anyway. Treatment of GI disorders with fiber is not based in good science, which we kind of alluded to in a previous lecture, but we're going to go into a little bit more detail here because it's such a big one. Low salt diet interventions to reduce blood pressure and prevent cardiovascular mortality are misguided. So we've heard this all the time. Oh, reduce your salt intake to improve your blood pressure. Well, let's really look at the data. Let's see what it's doing here. So recent findings, the recommendations for population-wide sodium restriction largely rely on one surrogate marker, blood pressure. However, recent evidence suggests that when looking beyond blood pressure, so heart rate, aldosterone, renin, cholesterol, triglycerides, noradrenaline, adrenaline, the net effect of sodium restriction is likely harmful. Prospective studies support the notion that those consuming the lowest amounts of salt are at the highest risk of cardiovascular events and premature events. Wow, premature death. Who would have thought? There is no definitive proof that sodium restriction reduces cardiovascular events or death. It is time for dietary guidelines to look at the totality of that evidence and reconsider the advice around population-wide sodium restriction. So let's look at them. Effects of low sodium diet versus high sodium diet on blood pressure and renin and a couple other markers. A Cochrane review of evidence. So they looked at 6,000 patients in 90 different trials, and the results were less than impressive. The author's conclusion, in white participants, sodium reduction in accordance with the public recommendations resulted in a mean arterial pressure decrease of about 0.4 millimeters of mercury. That's insignificant, if to say the least, in participants with a normal blood pressure, and a mean arterial pressure decrease of about 4, which is also not very significant, in participants with hypertension. Though there is weak evidence indicating that these effects may be a little greater in Black and Asian participants, the effects of sodium reduction and potential side effects to hormones and lipids were more consistent than the effect on blood pressure, especially people with normal blood pressure. So this is actually kind of mind-blowing because I, for one, even thought that salt caused hypertension because that's what I was taught in school. But through my own research, I've discovered that this is not the case. So how did we get here? So possibly the reason for the slight decrease in blood pressure is that these hypertensives are consuming less processed carbs, which incidentally also have high sodium. So that could be a reason they have lowering of the blood pressure. Because carbs, especially processed carbs, will spike your insulin, and you're going to have hyperglycemia. And hyperglycemia is associated with a lot more pathogens: hypertension, diabetes, the big three, So let's talk about the wrong white crystal, not salt, but sugar as the etiological agent in hypertension and cardiometabolic disease. So this is by Dr. D. Nicolantonio. Great and phenomenal research. Hats off to him. He is really paving the way so that we're not left in the dark ages here. So sugar may be a more meaningfully related to blood pressure than sodium, as suggested by the greater magnitude of effect with dietary manipulation. Reducing the amount of sodium in processed food may lead to an increase in their consumption, causing greater prevalence of cardiometabolic disease. Higher sugar intake significantly increases systolic blood pressure by 6 millimeters of mercury and diastolic blood pressure by 5 millimeters of mercury in trials of 8 weeks or more duration. The effect is increased to 7 when studies that received funding from the sugar industry are excluded. How interesting is that? Ingesting one 24-ounce soft drink has been shown to cause an average maximum increase in blood pressure of 15 to 9 millimeters of mercury and a heart rate of an increase of 9 BPM. Those who consume 25% or more calories from added sugar have an almost threefold increased risk of death due to cardiovascular disease. Fructose has been shown to stimulate sympathetic tone directly and indirectly by inciting insulin resistance and hyperinsulinemia. An increase in sympathetic tone from the overconsumption of fructose is one likely mechanism for sugar's ability to increase heart rate, cardiac output, renal sodium retention, and vascular resistance, all of which may interact to elevate blood pressure and increase myocardial oxygen demand. High fructose diet for just 2 weeks not only significantly increased 24-hour ambulatory blood pressure and increased pulse rate by 8%, but also increased triglycerides, fasting insulin, homeostatic model assessment, index of insulin and beta cell function. Excess fructose intake has also been shown to double the prevalence of metabolic syndrome. Current U.S. per capita intake of added sugars is approximately 2 to 8 times higher than current recommendations by the American Heart Association and the WHO. So even those guideline makers are up to the task. Considering adolescents specifically, current consumption might be as high as 6 to 16 times. Oof. Ingestion of sugars, including fructose, in their naturally occurring biological context, so as whole fruits, is not harmful and is likely beneficial. So, moral of the story is, it's probably not the salt that increasing blood pressure, but more sugar, refined carbohydrates, and by proxy, if you're eliminating refined processed carbohydrates, you're going to limit your sodium. So it might not be the salt so much, but the carbohydrates, and especially the processed carbohydrates, that are bringing down your blood pressure. So calories in, calories out as an intervention for weight loss. This often doesn't take into consideration metabolic health and quality of the food. Yes, you can count calories and lose weight, but protein leveraging, i.e. higher protein intake compared to carb, may be more important to metabolic health. And I know Lane Norton doesn't like to hear that. So high protein versus standard protein diets in overweight and obese patients with heart failure and diabetes mellitus. Findings of the ProHeart trial. So in this randomized controlled study, 76 overweight and obese patients, age about middle age or above, 72% were male, were randomized to a high protein diet, only 30% protein and 40% carbohydrates. I consider that actually a low protein diet, but for most people that's high protein, I guess. And then a low protein or standard protein diet, which was 15% protein, this minuscule amount, 55% carbohydrates, and 30% fat for 3 months. That's a lot of carbohydrates. Reductions in weight and cardiometabolic risk were evaluated at 3 months. Both diets were equally effective in reducing weight because they controlled for calories, right? Calories in, calories out. Lane Norton, talking to you. And waist circumference, 1.9 versus 1.3 centimeters. But the high protein diet decreased to a greater extent hemoglobin A1C, 0.7% versus 0.1%. And if we're talking from the primary care setting, if I see a patient that has a drop in 0.7% of their A1C, I'm happy for them. I'm saying you did a great job. Keep up the great work. Do whatever you're doing. They even improved their cholesterol and triglycerides when compared with the standard protein diet. The high protein diet also significantly improved both systolic and diastolic blood pressure than the standard protein diet. So that brings us back to the previous slide, indicating if you reduce your carbohydrates, your processed carbohydrates, maybe carbohydrates in general, it's maybe not the sodium so much that's lowering your blood pressure. Conclusions. Both energy-restricted diets reduced weight and visceral fat. However, the high protein diet, or I would say moderately high or minimally high protein diet, because that's not high by my standards, resulted in greater reductions in cardiometabolic risk relative to a standard protein diet. These results suggest that a high protein diet may be more effective in reducing cardiometabolic risk in this population. So, yeah, pretty big studies going on. I'm hoping more. I'm hoping that calorie in, calorie out kind of goes by the wayside and we start focusing on protein leveraging. So utilizing higher protein content in your calories to improve your metabolic health, not just weight loss. Weight loss isn't just everything. Looking good isn't just everything. It's what's happening on the inside. Your triglycerides, your A1C. These things are the real indicators of health. And visceral fat. That's a great one too. It's great that the calories in, calories out reduces visceral fat. Can't take away from that. We want to try to eliminate the visceral fat best we can. But if we can do this also by improving our triglycerides, improving our A1C by protein leveraging, we want to utilize that plus calories in, calories out, of course. So let's look at another study that shows that SECO isn't helpful for diabetics. Dietary carbohydrate restriction improves metabolic syndrome independent of weight loss. So very cool, showing the phenotypes here of these patients. Let's see. We prescribed intake and fed research participants controlled diets that maintain body mass, thereby eliminating changes in body mass. So these observations are different. They didn't change their weight. They just changed the composition of what they were eating. And the results showed that despite maintaining body mass, low carbohydrate intake enhanced fat oxidation and was more effective in reversing metabolic syndrome, especially high triglycerides, low HDL, and small LDL subclasses, which are the pathogenic lipid markers. Carbohydrate restriction also improved abnormal fatty acid composition and emerging metabolic syndrome feature. Despite containing 2.5 times more saturated fat than the high carbohydrate diet, a low carbohydrate diet decreased plasma total saturated fat. Wow, brilliant. We love to see it. So conclusions consistent with the perspective that metabolic syndrome is a pathologic state that manifests as dietary carbohydrate intolerance. These results show that compared with eucaloric high carbohydrate intake, low carbohydrate high fat diets benefit metabolic syndrome independent of whole body or fat mass. So again, another point in favor of the low carbohydrate diets, focusing really, maybe not so much on protein leveraging. A lot of these studies don't look at a high protein diet because there's still a lot of misinformation out there about high protein diets. But so long as we can help reduce those carbohydrates and replace them with other calorie sources, we might see benefits for metabolic syndrome patients. And maybe even people who are not even diabetic, right? Because we're all at risk. Let's face it, we're all at risk for diabetes, metabolic syndrome, heart attacks. Doesn't matter if you have family history or not. It absolutely doesn't matter. Ask any ER doc. Someone with chest pain and no family history of heart attack, you're assuming this person has a heart attack. It's not like, oh, you didn't have a family history of it, he doesn't have a heart attack. No, anyone can develop diabetes, high cholesterol, high triglycerides, obesity, diabetes. It doesn't matter who you are. That's why we have to start earlier, understanding protein leveraging, understanding that calories in, calories out. Yeah, it's great. You might lose weight, but if you're not focusing on eating the right things, you're going to be harming yourself in the long term. Let's just face it. Let's see. Stents for stable angina don't improve symptoms in a sham study. So this was a pretty interesting study, one that I don't think they could get away with in the U.S. They did it in Britain, and what they did is they put patients on the operating table, patients who had stable angina. So what is this? This is a patient who isn't having an acute heart attack, someone who is going about their day, maybe they get a bit twinge here, they have to take a nitro tablet to help them with the chest pains. So in current practice, we say, well, let's put you on an antiplatelet, maybe even a blood thinner in extreme cases, give you a statin, tell you to get some exercise. But if it's still not better, we give them a procedure called a stent. And this is supposed to improve their pain. So you put them under and you go up their groin with this little instrument, and then you put a little cage in there that dilates the artery. This is called a stent. In Britain, they did a study where they put these patients on the operating table, and in some, they cut them open at the thigh, didn't do anything. In the others, they actually inserted the stent. And then they looked. And what did they find? In patients with medically treated angina and severe coronary stenosis, PCI, which is the stent, did not increase exercise time by more than the effect of placebo procedure. The efficacy of invasive procedures can be assessed with placebo control as a standard for pharmacotherapy. So yeah, pretty cool. Let's see. Does back surgery fix neck pain? So I'm going to summarize this because I work with the spine surgeon, and I was able to ask him about this, about the studies, and why the studies are so confusing on spine surgery, because some are saying it does work, some are saying it doesn't work. So what's going on here? He's saying that the consensus is that if there is spondylolisthesis, then surgery can repair it. Surgery can sometimes even eliminate radicular pain. However, most surgery cannot fix axial pain, but some surgeons can improve it, including Dr. Duke. Dr. Duke is unique how he has one of the few published studies showing that his minimally invasive laser disc repair improves pain, which is extraordinary. He does it also in an outpatient setting, so you're not in a hospital, you're not at risk for infection and so forth. There's no hospital stay. You're in and out within 1 hour. You do a minimally invasive laser disc repair where he goes in through an instrument that's smaller than a straw and cleans up a disc herniation with a laser. And then the patient is put in a back brace and told not to bend down or lift more than 20 pounds. And, you do the instructions as indicated, and these patients, they do great. So I would like to see more research, and hopefully I'll be able to help them with that, maybe even publish some research showing more of this, because this is quite cutting edge stuff. And the literature out there, unfortunately, is a bit controversial whether surgery fixes back pain or not. And that may be for various factors, possibly insurance companies funding these studies that don't want to pay for surgeries. So there's a lot of reasons why these studies are showing mixed messages depending on who's sponsoring it. So I'm going to be watching this and hopefully even publishing my own research, so stay tuned for that. Fibrin, constipation, and irritable bowel syndrome. So again, we're showing that it doesn't really help too much. A recent study from Brazil found that a low dietary fiber dosage was not associated with constipation. Several studies that looked at fiber intake by people with chronic constipation did not find any difference in fiber intake compared to controls. Another study done in Germany with patients with chronic constipation. Patients were treated with Plantagova ovata seeds for about 6 weeks. They found that 80% of patients with slow transmit and 63% of patients with this disorderization did not improve with additional dietary fiber. There are also a number of reviews on the role of fiber in treatment of irritable bowel syndrome. So a review of 17 studies mostly showed, the psyllium or wheat bran only conveyed marginal benefits on global irritable bowel syndrome symptoms and constipation, emphasizing that insoluble fiber may even worsen clinical outcome. A meta-analysis of bulking agents in IBS was performed in Switzerland. After exclusion of low-quality trials, the odds ratio of symptomatic improvement with bulking agents did not reach clinical significance. Sad. So, fiber is not a cure-all for constipation. Hemorrhoids and fissures also, no, don't do them. May actually worsen these syndromes if you prescribe patients bulking fiber agents. So I wouldn't do that either. Fiber and colorectal cancer. So some people say if you increase your fiber, you're going to decrease your risk of colorectal cancer. Let's see. Do the studies support this? Dietary fiber protective? No. Yes. No. Majority of studies showing that no, fiber does not have a protective role for colorectal cancer. Sorry. Treatment of GI disorders with fiber is not supported by science. And they may even cause patients more symptoms due to their fermenting nature, right? A lot of fiber ferments in the guts. So patients with IBS or who should be following a low FODMAPs diet, look it up. It's a diet that excludes certain highly fermentable foods. It doesn't cure it, but it provides symptom relief for patients with IBS or who have a lot of bloating from gas and fiber. Because eating a lot of fiber causes gas and bloating. Sorry, vegans. Let's see. Low-fat diet interventions for heart disease. See my previous lectures. I did one on. It was probably my first one in this case in this series, part one, lipidology. And look at that one if you're interested. But Nico Antonio here, coming again, saving the day, discussing how there's no good evidence to support low saturated fat to prevent coronary artery disease. And I'm hoping that this is another thing that's going to go away, that more people are aware of. If you're not aware of it, click on the link, listen to my previous lectures on this. Conclusions. Prescribing low-salt diets have minimal effect on blood pressure. However, there are significant side effects and even increased mortality from a less than 6 grams of sodium intake per day, as prescribed by many institutions. High fructose and refined sugar diets and insulin resistance are the more likely explanation for hypertension, while calorie in, calorie out can aid in weight loss. High protein or protein leveraging, low carb, and nutrient density should be the focus of CECO, as these will preserve and even reverse dysmetabolism, or I should say preserve metabolic health and reverse dysmetabolism. A landmark British sham study demonstrated that stents are equal to placebo for improving stable angina. Traditional back surgery studies have very little evidence. However, the Duke laser disc repair is one of the few techniques with proven excellent outcomes. Prescribing fiber or increasing fiber for the treatment or prevention of various GI disorders is based on poor evidence, and we shouldn't be doing it anymore. Low-fat diet interventions to prevent heart disease is based on poor epidemiologic evidence and a disproven lipid hypothesis. That's all I have for you all on the interventions. I hope you all enjoyed this lecture. Probably things you haven't heard of before. I highly recommend you look at the source material. I'm going to post all links, or at least this slide where you'll be able to find all the links and read the studies for yourself. I hope you enjoyed. See you next time.